Well, great. So thank you, Rajesh, for the invitation and thank you for the very kind introduction. So as Rajesh said, I'm David Dufresne. I'm a assistant professor of pediatrics and mostly an epileptologist based in Sherbrooke. I have titled my talk today, So What Have We Learned Today? And anybody that trained at McGill around the same time as I will instantly recognize that this is a phrase that does not come out of nowhere. This is a phrase that was spoken from by Dr. Jeffrey Minnick pretty much every day that we had clinical duty with him. Um, Dr. Minnick, at the time, was the head of neurology at the Jewish General Hospital. Has always been a very astute clinician, but moreover, an incredible teacher. And to him, every case that we saw in clinical duty was a teachable moment. And he would make sure that we would end each and every day with each a personal clinical pearl to remember those cases by. And this is a little bit the basis of my talk today. So, okay. So I have no financial disclosure. I'm not that old yet. Learning objectives will be to recognize some peculiar MR phenotypes of epilepsy-causing lesions in the early childhood and infancy. Uh, Secondarily, understand the potential role of genetic investigations in the selection of surgical candidates. And finally, discuss the renewed indication for calosotomy in drug-resistant epilepsy. I will preface some of my slides with quotes that I find relevant. The first one is most usually attributed to Isaac Newton, but might have been from some earlier people. It is, if I've seen further than others, it is by standing on the shoulders of giants. And this is a bit how I feel presenting this talk today, knowing that most people behind me had CIHR grants, very active research career, and this is something that I do not have. I feel a little bit like this girl presenting this talk with a large number of great teachers behind me and me adding my little contribution on top and hoping it's going to be relevant to your practices. Margaret Mead had a quote that I found very appropriate and a little bit funny, which is always remember that you're absolutely unique, just like everybody else. So preparing this talk, I had to figure out what made my contribution unique. I do not have an established, recognized, and productive lab. I am not a specialist in SUDEP or status or any one subject in epilepsy, really. I have not yet established myself as a national leader. I have not influenced clinical practice, although I'm working hard and hoping that at some point I will be. What I do have, however, is a full-time position in an academic center that is a little bit peculiar in that our immediate metropolitan area is just over 200,000 people, which means that the bread and butter neurological consultation that we have, like global delay, febrile seizures, and things like that, we don't have that many. Our catchment area as a reference center is much bigger. And therefore, we have a lot of interesting consults, and we also have the time to pursue our interest around those cases and to go at the bottom of our intellectual questions. So we'll start with the first case, which started at 4 months, little H, which is a 4 months old male. And a quote from, I do not know if it's Andrea or Neda Bernasconi that said it first, but they certainly repeat it very often, and I think it is relevant to the case, which is that you shouldn't call an MRI as negative, you should call it non-diagnostic. So little H had his first seizure at the age of 4 months, a left arm clonic seizure, well, unfortunately, while he was traveling in the southern United States with his mom. He was referred to the local hospital, which of relevance is not an epilepsy center. They had their first seizure surgery in 2020, 2 years after this case. Had a 2 to 3 day admission, but almost a complete phase 1 evaluation. He had a head CT that was reported as normal, a head MRI, 1.5 Tesla that was reported as normal. Routine EEG demonstrated C4 spikes, C4 slow dysfunction, and a left arm then hemiphase clonic seizure with a C4 onset. He was discharged on levetiracetam, traveled back to Canada, and referred to me by his family physician upon his next visit. And I saw him first around the age of 5 or 6 months. By that point, he had normal development and physical examination. His EEG was congruent with the first one that was done. He had no seizure recurrence, but he was severely irritable since the levetiracetam. So I transitioned him from levetiracetam to carbamazepine. And one of the things that Dr. Ramesh Chandranare did not say is that I'm also an avid science fiction fan, and mostly a Trekkie. And one of the things that Star Trek did well was explore parallel universe and alternate history. So we will do something a little bit unusual with this case and explore the parallel universe where I pursued my PGY2 interest in multiple sclerosis and did a UCSF MS fellowship. And therefore, my advanced epilepsy training stopped at the end of PGY5 when I wrote my exam. So over the course of the next few years, this child had seizure clusters every 4 to 6 months, every time after weight gain, so we adjusted the carbamazepine. His development was initially satisfactory, but he did have an early left-hand preference. I would have repeated his MR probably around 18 to 24 months of age to take advantage of the advancing myelination, which probably would have been reported as normal. Around the age of 24 months, then we would have formally failed carbamazepine, probably would have started valproate at the time. In the next following months, seizure frequency would have increased to multiple daily seizures, rapidly failing valproate, clobazam, perampanel, the ketogenic diet. I would have referred to the neurosurgical center for an evaluation, which might have introduced some delay for evaluation, where I would have had a scalp EEG, PET, SPECT, during which point he was showing developmental regression. In all likelihood, this child would have been presented as an MR negative, PET negative right posterior frontal epilepsy, probably would have required SEEG, and with the current shortage of EEG techs, that would have introduced a 2 to 3 months delay, maybe more, which thereafter would have resulted in a resection at 30 to 36 months. Maybe that would have been if the SEEG was convincing. Could have been even worse. I could have had the results from the genetic testing, which showed a pathological mutation on a panel, which is associated with focal epilepsies. And as was my understanding when I was a resident, well, an MR negative genetic epilepsy is probably not surgical. This child would have evolved to severe developmental delay with probable toxicity from polypharmacy, and maybe a transition to a Lennox-Gastaut phenotype over the next few months. Now, in the real world, I was trained early on to look at my MRIs myself in all cases of epilepsy. And this is a single slice of the MRI that was performed at that American hospital. The whole MRI was of very poor quality. The T1 and the flares are almost unusable. The T2 is not bad, and I found something funky on this T2. So I remembered something that was taught to me by Dr. Christine Saint-Martin in my pediatric neuroradiology rotation years before, which is that the white matter can be abnormal in infantile FCDs. So increasing the contrast actually did demonstrate that it was a definite abnormality in the subcortical white matter signal in the right posterior frontal region. So we repeated that MRI at 7 months on our machine on a good protocol and a 3 Tesla magnet. And you can see on the right, the T2 slice displayed as acquired does show the abnormality, but is relatively subtle. But increasing the contrast, it is unmistakable that the subcortical U fibers have an abnormal low signal. And that was weird. But he was under control, so we didn't do much at the time with that. He did have the same seizure clusters. We did do the same carbamazepine adjustment. And he presented at 24 months with the same carbamazepine failure. The big difference there is that I approached him at that point with a probable diagnosis of right posterior frontal FCD. So I admitted him locally, did his surface EEG, the TEP, the genetic testing, and then presented him rapidly to the group. At the time, the repeat MRI showed a much more conspicuous lesion, but it remained visible and suggestive of FCD. One of my local colleagues with a lot of experience told me that she didn't have much hope for this patient. Despite the fact that we had a lesion, it was a patient that was regressing, had multiple daily seizures, and a genetic epilepsy. And she had the same understanding that I had a few years before, that genetic epilepsies were not good surgical candidates. But I did present him in surgical epilepsy conference as an MR positive, PET negative focal epilepsy, probable FCD congruent with the EEG and the semiology. And it was resected without further testing with the diagnosis of FCD2A. As of today, this child is now 3 years seizure-free, 2 years off medication. He had a minimal increase in his left arm paresis post-op, and in the next few weeks, he'll be starting kindergarten with no developmental concern. Now, the key to this case was not a 7 Tesla MRI. It was not waiting for proper myelination to occur, was not even post-processing or artificial intelligence. It was an initial questionable quality MRI, and it's white matter, and a high index of suspicion. So it did ring a bell from what I had heard in my radiology training years before, but looking at my books, I couldn't find anything looking like that. So I did a literature review, and literally the only thing that I saw that was similar was a publication by Ellen Cross from 2005, looking at Taylor type focal cortical dysplasia, as they were known at the time, that were obvious in infant and seemed to disappear at maturation of myelination. And if we look at the images that they had, we look at the top left image, it's exactly the same findings that we had, a subcortical laminar hypointensity on the T2 that suggests that myelin is locally advanced compared to the rest of the brain. So in the years that followed, 10 cases from our center were operated, including 4 cases that had imaging available below the age of 12 months. So we look at those and found out that out of the 4 cases, including the one that I already discussed, all 4 cases had T2 hypo signal where the FCD was eventually found. Now I show you the, sorry, other 3 cases here. The first case on the left, we can see on the subsequent MR that she has some very visible malformation of cortical development, but the hypointensity in the left posterior pole is quite unmistakable. Similarly, the middle case is a little bit more subtle when we look at it and we don't know that it's there, but the early 3 months 1.5 Tesla relatively low signal to noise ratio does show the abnormality very early on. Third and final case was considered an MR negative case when I saw her first, and we'll talk about her in a few minutes. And you can see that on the thick slices on the 3 years Tesla, 1.5 Tesla MRI, we cannot truly convince ourselves that there is something, but looking back, we see around that area of the pars triangularis that we have that hypo signal, and subsequently a good quality MRI showed one of the most elegant transmental signs that I've seen in my career. Now, what did we learn with those cases? Well, first of all, white matter maturation may highlight FCDs in infant with epilepsy. And the question is why? One of the tenets of early neuroradiology is that myelination follows function. And it's not quite clear exactly why. One could say that the deposition of myelin will allow the infant to make developmental progresses. But alternatively, we could also say that it really is the neuronal function that drives the surrounding oligodendrocytes to produce more myelin. Now, the 4 cases that I have here are FCD type 2, and there's, as we know now, an mTOR mutation or mTOR activation in FCD type 2. So there is a potential that this mTOR mutation drives oligodendrocytes differentiation. But there was also a case report of a patient with Sturge-Weber that had a very similar finding on his early MRI. And as we know, Sturge-Weber is a mutation that is present not in the neuronal tissue, but actually in the vascular tissue. So my hypothesis, and it would be interesting if somebody in basic science would take that on, is that really is the epileptic activity that drives accelerated maturation of the white matter over there. Now, another thing that we shouldn't have learned there, but that is reinforced by this case, is that reported negative MRs may in fact provide the diagnosis. As per the International League Against Epilepsy, a review of the MR scans should be done with semiology in mind. And moreover, they denote the importance of neuroimaging proficiency in epilepsy specialists, especially for cases like these, because a lot of cases will be reviewed by radiologists that do not have the semiology in mind and will miss the underlying malformation. Now, a little bit of a shout out to the young epilepsy section that just completed the first ILES course on advanced neuroimaging. It was an excellent curriculum. I encouraged the young epileptologists to attend that next year. And I believe they were saying that all the lectures will be available online thereafter. Now, second case we have, in fact, second case, third and fourth case are three females, a 12 years old and a 14 years old sister and their 16 years old first cousin with a working diagnosis of autosomal dominant nocturnal hypermotor epilepsy. Now, as I just said, we have three affected, two sisters and a first female cousin. We're all reported as hyperkinetic nocturnal, going from the worst affected having about 10 seizures every night to the other two having a few seizures every 2 to 3 nights. They did share a pathological mutation that was found after many years of disease. And while the 12 years old was described as having bifrontal FCD, the 14 years old sister and the 16 years old cousin was reported as MR negative. And Rajesh, do we take questions right now or?
At the end.
Okay. Now, similarly, the 12 years old initial PET performed at the age of 5 years old showed a left more than right anterior frontal lipometabolism and mostly left but occasional right anterior frontal spikes. That PET was performed in another center at the age of 5 years old during an initial surgical evaluation. And because of the bilateral described malformation, bilateral hypometabolism, and bilateral spikes, she was deemed to have no good surgical options. Now, at the age of 12 years, she was referred to me from a colleague whose question was specifically, I have this child with either bifrontal independent lesion or epilepsy versus a genetic drug-resistant epilepsy unrelated to the lesion. Is she a candidate for vagal nerve stimulation? I had a few red flags in that case. So the presence of a lesion was bothersome to me, as well as the fact that she had a single semiology that was stable in time since the onset of her seizure that is not quite typical of nocturnal hypermotor seizures. She did, in fact, have focal motor hyperkinetic portion in the seizure, but it was preceded by an emotional aura and followed by asymmetric tonic posturing. So I had some time and I asked my colleague to sit down with me and review the case. So we looked at the images that we had. And fair enough, we can see that there is some thickened cortex that is abnormally gyrated in the mesial left frontal region, with a suspicion of either polymicrogyria or pachygyria on the right, which is actually what was reported. And the PET at the time, fused with DMR, demonstrated a mostly left-sided, but also slightly right-sided hypometabolism. Now, the PET was not too bothersome to me. We know from experience that the PET scan hypometabolism oftentimes extends much beyond the zone of the lesion and corresponds mostly to the symptomatic zone and not to the lesional zone. So we went back to the initial MRI for this case, and we did see, as we saw in the first case, that we had abnormal myelination in this child. But the abnormal myelination was one-sided, which was a little bit interesting. And finally, the genetic testing in this case showed a pathogenic mutation in UNPRL3. Now, this case was seen at the end of 2020, was starting to be known that focal cortical dysplasias, at least the idiopathic ones, had somatic mutation in the mTOR signaling pathway. What was a little bit less understood was the impact of that in cases such as these of familial focal epilepsy with variable focus and how that impacted the epileptogenesis in those cases. One of the hypotheses that is still current, I think, is that there is a somatic second hit in those patients, which therefore results in random location of the focal cortical dysplasia, as well as unaffected carriers. But what about the sister and the cousin that were reported as MR negative? So maybe we could have a different mechanism for the epilepsy with the same mutation. We know that mTOR is involved in also synaptogenesis, protein synthesis, neurotransmitter synthesis. So they could have non-lesional epilepsy. Could it be also unrelated to UNPRL3? What I did not tell you is that the first sister also carried the MTTK mutation, and she had the high percentage of her mitochondria that were affected, but she did not have any of the other features of MERF or MELAS. So that was maybe possible, but not probable. My main concern was that we might have had suboptimal imaging in the sister and the cousin. So we looked at the sister first. She also had onset of seizures at 6 or 7 months. She was not hypermotor. She was focal motor with impaired awareness, starting with either no clinical sign if it comes out of sleep, or a vague aura if it comes out of wakefulness, progressing to asymmetric tonic posturing with the flexion of the right upper extremity and extension of the left, then leftward head and eyes deviation, progressing to bilateral tonic-clonic. Her CMLG was also stable since onset. Her EEG was similarly stable over the years, with mostly F4 spikes, occasionally F8 and C4. Latest images available were performed at 3.5 years, relatively good quality MRs, but thick native cuts, and was reported as MR negative. Looking back at that, I can see the lesion, but I cannot truly convince myself if I'm only looking at those, not knowing where the lesion was ultimately found. And certainly I could argue that there are areas of increased cortical thickness in multiple areas there because of volume averaging. Now, we also had images performed at 8 months in an pars triangularis, as I've shown earlier after the first case. We do have the increase in the myelination. So we went ahead and performed a update MRI on our 3 Tesla machine using the RNS protocol and demonstrating that nice FCD here with an increased cortical thickness, blurring of the gray and white matter differentiation, the very nice transmental sign. And on a PET MR fusion, we see that that cortical area actually shows decreased FDG uptake. So 2 out of 3, not bad. We're left with the cousin. She's 16 years old at that time. Unfortunately, the onset was at 2.5 years, so we cannot cheat and go back to the infantile MRI. She does have a non-hypermotor seizure. She starts with a vague aura, then right hemidystonic seizure, oftentimes progressing with asymmetric tonic posturing, then right hemiclonic, going to bilateral tonic-clonic seizure. Her evolution was a little bit atypical in that she has an explosive onset of seizures, hard to control for about 1.5 years. Then around the age of 4 years, went into a prolonged remission, 7 to 8 years without seizure, and many of those years without medication, then relapsed at 12 years and progressed rapidly to drug-resistant epilepsy. Her EEGs, apart from the period where she was in remission, for the most part showed C3, P3 interictals, and on one single EEG in 2007 had rare P4, P8, and O2 spikes. Previous EEGs at 2.5 and 12 years were reported normal. So I was going into this case thinking about probably an MR negative or MR non-diagnostic, I should say, left frontal epilepsy. So what did we do? Well, we repeated the MR on our machine with the RNS protocol. We couldn't find anything. And both me, the surgeon, and the neuroradiologist sat down looking at what we knew from the neurophysiology and the seizures and couldn't find anything. PET-MR fusion similarly could not find an area of hypometabolism. Surface video EEG showed the same thing as before, and we couldn't record diurnal seizures, so SPECT was not easy to obtain. So what next? There's many things we could have done, but we chose at that time to send the images that we had to Andrea and Neda and the MNI to put them in their post-processing using texture analysis. In the middle row, what we have is a quantification of the blurriness, or in fact of the contrast between the gray matter and the white matter. So the higher signal means a higher contrast between the gray and the white matter, and the lower signal means increased blurriness. And the lower panel is a relative intensity map, so a normalized T2 flare signal quantified and expressed in a color like this. And what we saw is decreased signal in that mid-cingulate sulcus here with on the contrast images, and an increased signal in the intensity map here. And lo and behold, going back to the raw images, it was always there. It's just so small that even having good EEG data, good semiology data, we couldn't see it. But it was there. We can see, and I hope it's as good on your screen as it is on mine, but we can see the increased thickness, the blurriness, and if one squints a little bit, maybe even a transmental sign going to the ventricular surface. So all 3 of them were resected without even going towards SEEG. All three of them resulted in a diagnosis of FCD2A on pathological specimen, and they've all been seizure-free since the surgery. And I had a little mini heart attack when they came back to clinic because the parents decided to stop the medication very rapidly, which is not what I would have done, but you can't argue with the result. Now, what have we learned today? So we have to be careful with the semiology. Parents will describe it one way, the children will describe it one way. And if we're not careful, we're going to have some biases there. I remember quite distinctly the first time I was on epilepsy service with François Dubois, and thought we were doing a pretty good job at doing a clinical history. And then Dr. Dubois swoops in and does a whole other level of semiological history. And it was a very humbling experience, but a great learning experience. We also have to be aware and avoid cognitive biases. And in this case, ensuring bias was a big problem because there was an early fixation on the fact that there were three people in the same family with something that looked hypermotor. So they had a diagnosis at the time of what was known as ADNFLE, which is known as autosomal dominant hypermotor sleep-related seizures now. And the finding of an NPRL3 mutation afterward was not reinterpreted as discordant with the phenotype or discordant with the diagnosis. It was interpreted as, well, maybe there's not a good genotype-phenotype correlation, and this is ADNFLE with an unusual gene. And more importantly, we learn from these cases that not every genetic epilepsy is an ion channel or receptor defect, which we should know. To me, the two prototypes of genetic epilepsies are on the one hand, Dravet syndrome, which is a channelopathy, but also tuberous sclerosis, which comes with a lot of lesions. But as time goes by, we learn more and more genes that are related specifically with malformation of cortical development. Some of them make sense, like genes involved in cell cycle or cell growth regulator, like Gator complex, the RAS pathway, mTOR and such. Same thing for cytoskeleton and microtubule organization and function, which are important in patterning and cell migration. Interestingly, some channelopathies are also associated with focal cortical dysplasia. More than that, I think it shows that unexplained drug-resistant epilepsy requires some genetic investigation. First of all, because specific therapies are now in the pipeline that will come to fruition and could help us choose some better medicine for the patients that are not surgical candidate. But that in some cases, and especially in the familial focal epilepsy with variable focus, mTOR pathway genes, and maybe others, the actual specific therapy for those patients may actually be surgery. And therefore, the degree of suspicion should be very high, even if the MR is called negative, in which case they probably should be referred to a center that is an expert in imaging of epilepsy. Interestingly, there was a recently described paper looking at detection of somatic mutation in microspecimens of cortical dysplasia using cells gathered on SEEG electrode, which could help you target the resection. But building on that, more interestingly, is that maybe epilepsy could borrow from oncology. And in oncology, they've started a few years ago doing liquid biopsy using cell-free DNA to diagnose the tumors. And we have a few technical hurdles towards that, but maybe down the road, we could prove the presence of an underlying undiagnosed FCD by looking for those mutations in CSF-derived cell-free DNA. And one step ahead of that is if we could design mTOR metabolism-dependent markers, maybe we could eventually highlight those FCDs in nuclear medicine. Now, moving on. Citation now from Stephen King that says that it's best to have tools with you. If you don't, you are apt to find something you didn't expect and get discouraged. And this will make sense in a few slides. So, 33-month-old male with no relevant past medical history or family history developed seizure between the age of 12 and 16 months. And for some reason, he was first evaluated by neurology at the age of 22 months. It is not a matter of waiting list with a very short waiting list here. I think the seizures were initially unrecognized by the parents. And when they were recognized by the parents, they were somewhat reassured by a family physician that told them that it looks like cramps. And the pediatric neurologist in the room will know exactly what they were at the time if we're saying seizure that looked like cramp. Initial development below the age of 12 months was unremarkable, but with the onset of seizures, he had a plateaued and a regression in his development. And his physical examination revealed subtle right hemiparesis and an early left arm dominance. Inaugural seizure, as described by the parents, were either myoclonic seizures or epileptic spasms. Down the road, they were probably more epileptic spasms, even though the parents were saying that they were very, very short in duration and usually isolated. They were initially seen daily, increasing to tens of seizures per day upon the first evaluation at the age of 22 months. But when we saw him first, he had developed other seizure types. Second seizure type was bilateral motor atonic seizure with an abrupt loss of tone that usually ended up with a fall. He had multiple falls with injury. Those occurred multiple times per day. He actually required a helmet for safe ambulation by that time. Third type of seizure were generalized motor tonic seizure, affecting mostly the axial musculature, sometimes the appendicular musculature, lasting approximately 10 seconds, had them multiple times per day. I saw this patient a few months after the first evaluation. By that time, he was on vigabatrin for the suspected spasms, and those generalized motor seizures were not present anymore. And then upon EEG recording, we also recorded some atypical absence, 10 to 40 seconds loss of contacts with a relatively gradual recovery, not a really sharp recovery like we have later on in typical absence. Those were not really noted by the parents, but they were recorded on EEG and associated at that point with bifrontal bursts of spike or polyspike wave complexes. At the age of 33 months, he had failed multiple medication as well as the ketogenic diet. He was on tritherapy with valproate, vigabatrin, and clobazam. His CGH and next-gen sequencing and some variants of unknown significance that were not contributive. But his EEG was always interesting. While there was a lot of encephalopathic features, diffuse features, there was a clear excess of abnormality on the left hemisphere, both in background abnormality with excess of delta and theta activity, decreased spindles during sleep, but also in the spike activity that were multifocal, but with a clear predominance on the left. Now, his MRI was initially regarded as non-diagnostic. He has an obvious arachnoid cyst on the right, and there's that hyperintense signal on the left that was initially considered by the radiologist to be an artifact from the technique. But upon further review with him, we came to the conclusion that it followed the anatomy too closely to be artifactual. And in fact, looking at the T1, the corresponding T1, we can see that the parasagittal area on the left shows increased thickness, maybe abnormal gyration, definitely a bit of blurring. So we're relatively convinced that there was something abnormal there. Here, just for good measures, I provided with the axial. We can see the same thing, seems to have a very laminar signal abnormality, follows the U fibers, if anything. And in the first top left 3 or 4 images, we can see that there's some increased cortical thickness in the parasagittal area. So we approached this as something lesional. We requested a TEP scan. TEP scan was interesting, showing an hypometabolism or decreased FDG uptake, also in the left hemisphere, but more laterally in the temporoparietal area. And looking at the sagittal T1 at that point, we can see maybe some polymacrogyria or abnormal gyration in the frontoparietal operculum and in the posterior parietal region. So I discussed that case with my usual neurosurgeon, and we approached this one as an epileptic encephalopathy that likely started with initial spasm, but was progressing to a Lennox-Gastaut phenotype. EEG and physical examination were suggestive of a left hemispheric origin, or at least a left hemispheric predominance, and the MR and the PET were suggestive of extensive left hemispheric lesion of uncertain nature. So our initial approach was to think, well, maybe we can offer this child with a very poor seizure control, terrible development, a primary intention hemispherotomy, even though his motor deficit is relatively subtle. But we didn't feel comfortable doing that without at least reviewing these images with someone that is a neuroradiologist. Now, a neuroradiologist, and that's where the quote from Stephen King comes in, said, well, I agree, there's extensive dysplastic changes in the left hemisphere, but there's also white matter signal abnormalities in the right temporal and insular region, which in retrospect, I think is an artifactual problem we have with our young MRIs here, that the head is often not in the center of the magnet, and therefore we have a gradient of signal. It was definitely not following the anatomy like it was in the left hemisphere, but she was suspicious that the right hemisphere was not normal as well. So we didn't feel comfortable offering a primary hemispherotomy with very minimal deficit in a child that may also have epilepsy from the right hemisphere. So that was at the end of September of last year. And we had a chance meeting in the airport after the Canadian League of Epilepsy meeting with Arya Fala, and just for interest's sake, discussed the case with him and came up with a plan of a two-step approach with initial chalazotomy, which in any case was the appropriate approach for this child that had function-limiting drop attacks. And then if the hemispherotomy helps us lateralize the seizure onset, maybe a second step hemispherotomy. And the hemispherotomy never occurred because the chalazotomy was performed in October of last year. He's been seizure-free since then, and up until now, and I have to call him after this talk, we've weaned 2 out of 3 medication, and we're going to start weaning the 3rd one soon. His EEG is almost normalized, and what is left is rare left hemispheric spike and mild slow dysfunction on the left hemisphere as well, with a completely normal EEG in the right hemisphere. And while he still has significant developmental delay, he is now making progresses, which he was not doing before. Now, just for interest, on the left, we have a panel of his sleep EEG 3 months pre-op. And on the right, we have, with the same settings and same montage, a panel of his sleep EEG 2 weeks post-op with a complete normalization of the EEG on the right and intermittent spikes and slow activity on the left hemisphere. It's a drastic change. So what did we learn? So it reminded us that chalazotomy is a viable option outside of the classical indication for drop attacks. And during my residency, we were not performing many chalazotomies. I think it had been succeeded by vagal nerve stimulation for the epileptic encephalopathies at the point, because chalazotomy was considered to be a palliative approach. We did not expect to have seizure freedom from chalazotomy. And compared to vagal nerve stimulation, it was much more invasive. So the families oftentimes did prefer vagal nerve stimulation. Interestingly, there's been a renewed interest in the procedure in the last few years. There was a lot of publication in the 1980s and 1990s, but almost nothing in the early 2000s. But I remembered from having a lot of time on my hands at the beginning of COVID with the lockdowns, reading this article, which was a meta-analysis from seizure freedom from chalazotomy. And it is far from menial. They did demonstrate that almost 20% of patients post-chalazotomy were seizure-free, and more than half patients were free from drop attacks. And complete seizure freedom was predicted apparently by the presence of spasms and a shorter epilepsy duration. In the same time frame, there was a almost as interesting, or maybe more interesting paper that was published, much smaller case series, 56 patients with MR negative epileptic spasms. And in those patients that failed the conventional medical treatment for infantile spasms, 42%, almost 43% were free from spasms, and 1 in 3 was completely seizure-free, which is great considering that the outcome of drug resistance in spasm is almost universally poor. So some groups picked up on that and started thinking that maybe chalazotomy should be offered more liberally in spasms. Dr. Fala actually said that this is one of the things they offer on a relatively regular basis for drug-resistant, non-clearly focal spasms at UCLA. And a Japanese group came up with a bit of a flowchart for those. If you have a clearly lateralized case that fails medication, then they would go for resective surgery. But in non-lateralized cases, they would start with a corpus calozotomy. If the patient is seizure-free, then great. And if he is not, and the calozotomy helped to lateralize the lesion or the epileptic activity, then would go towards additional resective surgery. I think this is a fair approach, to which I would just add early genetic testing with all the potential for individualized therapy that are coming up nowadays. Now, as I was saying, there was a little bit of a lull in the interest towards chalazotomy in the literature. This is a simple chalazotomy PubMed search from 1975 to 2023. And from 2000 to 2010, there was almost nothing. But we can see that since 2010, the interest in calosotomy in the literature has increased significantly. What I find interesting is that a lot of the publications also describe new, improved, and minimally invasive techniques for calosotomy. And if the primary problem with calosotomy is the fact that it is more invasive than neurostimulation, then maybe those could make it more acceptable by the families. Another question was, what was the cause of epilepsy? His left hemisphere seemed clearly abnormal, but we didn't have a clear idea of what it was. And looking at hyperintense T2 flare signal in the literature, we came up with this article from Ingmar Blumke's group that describes a variable phenotype for Moge that goes from an hyperintense laminar signal in the T2 flare in the very young children with Moge that goes on to evolve and disappear to be afterward just a thick, blurry, and increased contrast cortex. So we thought that this was quite compatible with our case, and we have therefore a provisional diagnosis of probable Moge for him. And this becomes interesting because that would be a distinct MR phenotype for early childhood Moge, which, as we know, is associated with a mutation in SLC35A2. And SLC35A2 is a gene that controls protein glycosylation. And the same group has recently done a trial in very few patients, but still, of galactose supplementation and treatment of Moge. It had been done in the past in SLC35A2 glycosylation disorder syndrome, which is a germline mutation and not a somatic mutation, showing an improvement in their biochemical abnormalities. And Dr. Blumke's group actually showed out of the 6 patients that they tried on the supplementation, 3 of them had a worthwhile reduction in seizures, and 1 had complete seizure freedom. So if and when my patient that still has this malformation in his brain starts having seizure again, this is certainly something that I'm going to be considering. It is experimental medicine. We have to take that into account. But if I have the choice between something that is an oral supplement that is very well tolerated and an hemispherotomy in a patient that has very minimal deficit, I'm going to give it a try. Now, take-home messages. I don't think I can do quotes in a medical presentation without quoting William Osler. One of the quotes that I like from him is that the value of experience is not in seeing much, but in seeing wisely. So I think we've shown that the white matter in early childhood epilepsy can be the key to understanding what's happening. Both in focal cortical dysplasia and in Moge, it can be a very powerful tool to find those lesions. It bears to be repeated that we have to become used as epileptologists to look at our own MRIs and also to develop a close collaboration with our radiologists. It is important to review those cases in collaboration with them and to work with them to develop good quality MR protocols for epilepsy. Similarly, genetics can be incredibly helpful as a tool, sometimes to screen out surgical candidates, but also to root in surgical candidacy. And I would argue that if we have an mTOR pathway mutation and maybe some others, we have to have a presumption of the presence of an FCD, even if we cannot find it initially. And finally, calosotomy is not only a palliative option, and in some cases can actually result in great outcomes. One last message, and a quote from probably one of the greatest thinkers of the 20th century: somewhere something incredible is waiting to be known. And I want to turn that into a little defense of the humble case report. Now, as we know, case report and case series are at the bottom of the pile when we're looking at the quality of evidence. It is anecdotal, it is hugely susceptible to publication bias, and we cannot usually use them to infer causality. But I would retort with this case report that it will not read, but every pediatric neurologist will recognize that as the first ever case report of West syndrome, published by William West himself talking about his child. And from that case report, a whole field of research was born, and it is now one of the greatest pathologies that we have to treat in pediatric neurology. Now, case report and case series can be a great starting point towards more formal study. And as my research supervisor says, what I call a case report in clinical medicine, they call preliminary data. It is oftentimes a good way to anchor in a student's mind some new knowledge, and they will remember it a lot better if we talk around a case than if we just talk about a book. And sometimes it is an impetus to change clinical practice. If I go back to chelosotomy, I think the last chelosotomy before this case at the Montreal Children's had been in 2014. And since last fall, I think we have been performing 4 or 5 chelosotomies, all of them not necessarily with incredible results, but all of them with worthwhile results. So it is an important tool in our arsenal that we had kind of put on the wayside because we had other tools that seem to be more elegant, but can be quite useful. What that would require, however, is to be very methodical with it. It requires careful and precise documentation, adherence to reporting standards, and a willingness to report and publish also the negative outcomes. Would benefit from a standardized data intake, from more data gathering and data sharing in the community, and definitely from more support from academia. The universities are not usually willing to give a lot of money to go and present case reports. They'd rather have RCTs and basic science data. Now, I will go back to my initial quote, and I do not have lab mates and students to thank for this presentation. What I have had, however, is a great wealth of incredible teachers that have brought me where I am, and without whom I would not be the neurologist I am. And even way before that, my first and by far dearest person with epilepsy in my life, my little sister. On the left side, based on the burgundy couch and the fact that my brother is a pacifier, I would say this is about 1990, which is the year where she started seizing. And on the right side, based on the fact that I have a cleanly pressed shirt and all my hair, that would have been early residency. And we can see that she's doing great. She's actually finishing a bachelor's in special education. But definitely having somebody like that in my life drove me to be fascinated by epilepsy and by treating those people. And with that, I thank you all, and I will take comments and questions.